Well, good morning. I have a great pleasure to interview Dr. Greg Piazza from Brigham and Women's Hospital and Harvard Medical School. He just gave us grand rounds on state-of-the-art in management of acute submassive and massive pulmonary embolism. So we're going to pursue a little bit more on that topic. So Greg, I want to ask you a question because this is sort of the million-dollar question that's on all of our minds when we start thinking about how to take care of these patients. Where do you think the pulmonary embolism response team is going to go in the next 5-10 years?
So I think that the pulmonary response team, first of all, it's a measure of quality of care that we provide to our PE patients that a lot of hospitals are actually adopting. So first thing, it's already spreading like wildfire, and I expect that it's going to become almost a requirement for hospitals to have some kind of response team for PE that's going to make sure that patients are going to achieve the best outcomes they can. I think different centers have a variety of ways of implementing a PE response team, but I think some of the things that I see over the next 5 to 10 years that are going to be universal will be algorithms for evaluating patients with pulmonary embolism, probably based on guidelines that we currently have in the literature or some iteration. Outpatient follow-up for these patients, that's going to be really critical because we know that once we get patients through the acute phase of pulmonary embolism, there's still quite a bit of work to be done. There's determining the optimal duration of anticoagulation, there's monitoring them for pulmonary hypertension, there are a host of issues related to anticoagulation, especially with all the options that we have available. So having some kind of a clinic experience to complement the inpatient PERT team is necessary. On top of that, there's going to be a strong need for every PERT team to actually track their outcomes and store data. One of the things that we understand that's a real benefit of a PERT team is actually finding out how different providers treat PE, finding out the outcomes, and then applying that data to kind of standardize the approach at a medical center for certain manifestations of pulmonary embolism. For example, if you have a very active surgical embolectomy program, you'll want to look at the outcomes for surgical embolectomy in your PERT team and see if you can identify the patients who in general will benefit more from a surgical embolectomy than another advanced technique, identify them more quickly, and perhaps take some of the decision making away from individual providers.
Great. So to follow up on that a little bit more, you kind of get a very broad view as a part of a PERT team as far as therapies for acute pulmonary embolism. Where do you think the technology really needs to go? Is it somewhere in diagnosis? Is it somewhere in risk stratification? Or is there something more as far as the actual treatment that can really be improved over, again, the next 5 or 10 years?
Oh, that's a great question, and I think for diagnosis we've really reached a great place where we have CT technology that's widely accessible. The yield for CT is excellent. We're picking up, as a matter of fact, we're probably picking up some PEs that the clinical significance may be actually in question for these very small subsegmental filling defects. But certainly I think sensitivity-wise we're doing really well with our current state of CT technology. In patients that the CT is negative, the chance that we're missing something clinically important is incredibly small. So I don't see really any major advances in diagnosis that could change what we're already doing. But I do think for the areas of treatment and risk stratification, there's potential for great growth. For risk stratification, we need finer techniques for parsing out especially the submassive PE or intermediate risk PE population, because we know that even in that group there's a lot of heterogeneity. If you have a patient with mild RV dysfunction and a small troponin, they're probably very different prognostically than someone with severe RV dysfunction, severe pulmonary hypertension, and a high troponin. And we want to be able to identify which patients are really going to benefit from advanced therapies. There are other biomarkers out there that have been evaluated, something called heart-type fatty acid binding protein that rises more quickly than troponin, that may be helpful. Not every center has access to it. It is an expensive biomarker, but there is the potential that some new biomarker will come out that will enable us to refine the way we look at patients. Looking at the RV to LV ratio on CT is very helpful. You don't really need any other test other than what you use to diagnose the PE. You just use the same data and look at the RV to LV ratio in the axial images. That's very handy. It gives you prognostic information. It also helps interventionalists and surgeons localize where the PE is so they can see if it's even feasible to try for an embolectomy. You know, if they have very distal involvement, it may not be something that surgeons or catheter-based specialists can reach. So I think that we still have some room for growth in risk stratification. For therapy, I think that's another area where we could stand to push the field further. We know systemic fibrinolysis is effective. There's not that question. Where there's a problem is the safety of systemic fibrinolysis is not where we really want it to be. We have to tell our patients about the risk of major hemorrhage, in particular intracranial bleeding. A lot of patients aren't willing to undertake that risk. A lot of providers are hesitant to actually run the risk of causing a patient an intracranial hemorrhage. If you actually look at the Healthcare Utilization Project and you look at rates of systemic fibrinolysis, even for massive PE, it's really on the decline. So I think all these providers are really crying out for some other method of reducing the mortality associated with PE without causing bleeding. And so I think some investigation is really focused on low-dose systemic fibrinolysis to maybe achieve the same efficacy without causing as much bleeding. We don't actually really know what the ideal sort of sweet spot for systemic fibrinolysis is. We studied 100 milligrams. Now there are data showing that 50 milligrams seems to work well. What about 25? What about 10? We don't know. Some investigators are interested in catheter-based techniques. Catheter-based fibrinolysis lets you combine pharmacological therapy with a low dose of fibrinolytic drug and mechanical disruption of the thrombus to kind of facilitate the dissolution of the obstruction. And that's a very hot area of research, especially with regards to ultrasound-facilitated catheter-based fibrinolysis, but there are other catheters as well. There's also an interest in purely mechanical techniques for embolectomy via catheter, suction or retrieval devices, and we're in the early stages of evaluating that, and that would potentially give you the option of removing the obstruction without really causing bleeding, because there wouldn't be any fibrinolytic. There'd be all of the complications that are associated with an invasive procedure, but you wouldn't have that specter of intracranial hemorrhage that you would when you use a fibrinolytic-based approach. And who knows what other techniques are on the horizon. Surgical embolectomy continues to be something that is being refined. The outcomes are better and better with each clinical series that's published. And we probably reach for that not frequently enough. So I think there's going to be a lot of growth both in studying these advanced techniques themselves, but also in identifying which patients may need a certain technique more than others. And I think once we really start to get focused on that, that's when we'll see some outcomes improvements. And one of the great things is just seeing that now people are getting interested in pulmonary embolism. They're getting interested in the therapies and the outcomes. You know, we've shown that when we turn our focus to cardiovascular disease, when we hone down on things like myocardial infarction and heart failure, we can actually push the bar to heights that we didn't think could be possible. And now I see that that's going to happen for pulmonary embolism, and it's an amazing time to care for these patients and to be involved in research and quality initiatives.
Great. Okay. Well, thank you very much.